Para formar e pôr em ação fisioterapeutas de excelência nas UTIs, está entrando no ar mais um episódio do podcast UTI em Forma e Ação. Eu sou Saint-Clair Bernardes, fisioterapeuta intensivista, e você me encontra lá no Instagram, no @Saint-Clair Bernardes.
Eu sou a Débora, fisioterapeuta intensivista, e você me encontra na @movimenta_UTI. E juntos você nos encontra na sua plataforma preferida, no Spotify, no YouTube, onde você quiser ouvir e ouvir um episódio novo e muito especial. Estamos fechando o nosso mês de aniversário e para comemorar o nosso 1 ano, a gente tem um convidado extremamente especial. Eu lembro uma vez, sabe, Saint-Clair, que eu estava indo para um congresso internacional, o Congresso de Reabilitação Europeu, né? E aí eu lembro que eu mandei um pôster e aí eu recebi um e-mail de confirmação, né, da apresentação. Na verdade, nesse foi o que eu apresentei oral. E eu recebi a confirmação da apresentação e tinha a assinatura dele embaixo. E aí eu falei, não acredito, eu recebi o e-mail dele. É uma pessoa que acho que todo mundo que está dentro da terapia intensiva já leu algum artigo dele, né? Talvez não tenha reparado que o nome dele estava ali, que ele era um autor
Às vezes não
daquele
ligou o
artigo.
nome, a pessoa e a importância da pessoa.
Exatamente, mas com certeza já leu. E assim, com certeza você faz, se você. A gente teve um episódio de prática baseada em evidência, né? Se você faz uma prática
Isso.
baseada em evidência, com certeza você já fez alguma coisa que foi ele que estudou e que chegou ali. Então, pra gente é um episódio extremamente especial, com um convidado muito especial, né, Saint-Clair?
Muito, demais, Débora. É uma honra muito grande para a gente no podcast, desde o nosso propósito há 1 ano atrás, né, fechando esse mês de aniversário, que é trazer coisas boas e fortificar, engrandecer a nossa especialidade, pensar fora do óbvio. Talvez a gente possa escutar aqui uma história completamente fora do óbvio, no sentido de que foi uma pessoa que ajudou a construir a história da fisioterapia na UTI, né? Ajudou e ajuda até hoje. Então, o nosso convidado de honra, muito especial, e para mim, e tenho certeza que para a Débora também, assim, algo muito marcante na nossa trajetória profissional, poder conversar com ele hoje, é o professor Rik Gosselink. O professor Rik Gosselink, ele é professor emérito em Ciências da Reabilitação pela Universidade de Leuven, na Bélgica. Ele tem uma vasta história de publicações, de artigos científicos, livros e etc., e participação em todo tipo de evento que você possa imaginar dentro da fisioterapia. E a gente tem um prazer enorme em recebê-lo aqui para que a gente possa ouvir sobre o passado, sobre o presente, sobre perspectivas para o futuro, sobre o olhar de uma pessoa que fez parte de tudo isso que a gente vive aqui hoje, né?
Exatamente. Isso que eu acho que é o mais legal, sob o olhar de alguém que presenciou essa jornada inteira aí, né? Então, a gente segue aqui, né, com o nosso propósito, como você falou, de tentar oferecer o que tem de melhor dentro da nossa profissão para quem acompanha a gente aqui no podcast. E eu tenho certeza que a gente finaliza esse mês de 1 ano de podcast com esse propósito cumprido. Afinal, vamos receber o Rik Gosselink aqui. E eu tava falando do e-mail, né, Saint-Clair, e eu lembro que na época me chamou a atenção, porque eu falei, nossa, ele é tão top, e é ele que tá respondendo o e-mail, é ele que tá organizando as apresentações, né? Então é muito legal a gente ter como referência pessoas assim, né? Pessoas que são extremamente inteligentes, mas que são extremamente engajadas e que apoiam, né, outras pessoas, né? Ele foi muito rápido em nos responder e estar aqui
Solícito.
com a gente, muito solícito. E isso também faz parte do nosso propósito, né? É agregar pessoas, engajar pessoas. Então, fica aqui com a gente, né, Saint-Clair?
Isso mesmo, nos acompanha, a gente vai ter um episódio excelente, o episódio obviamente vai ser conduzido em inglês para que a gente possa conversar com o Rik, e de início a gente vai estar com as legendas disponíveis automáticas no YouTube, para mais em breve a gente ter uma tradução mais específica, e no Spotify, obviamente quem está nos ouvindo aqui no Spotify, o episódio vai ser conduzido sem tradução em inglês, mas se quiser ver depois da tradução, nos acompanhe e aproveite para se inscrever no nosso canal do YouTube. Então vem com a gente, né, Débora, para esse episódio muito especial.
Hi, Ricky. Thank you so much for your participation in our podcast. It's a big pleasure to have you here. Thank you very much.
No, it's really my pleasure. It's really an honor. to be in this podcast. Actually, it's my first one being in a podcast. I've been, of course, in sessions on internet over the last 2-3 years, but podcast is relatively new for me. So thank you very much. Muito obrigado.
Thank you, Rick. Okay, de nada. You are welcome. Thank you, Rick, for your time and for talking to us. It's a really special episode that we have on the podcast, and because of your history and everything that you represent for the physiotherapy and for the team, the title that we chose for this podcast. We're going to talk about the physiotherapy in the ICU, and we are going to talk about the past, the present, and the future. What do we hope for our profession, and what have we done for our colleagues and friends that work with physiotherapy in the ICU?
In this
Okay.
month, Ricky, we are me and Saint-Clair are celebrating 1 year of podcasts in this month.
Yes.
We
Yeah,
are 1 year talking about ICU and the other topics about ICU and physical therapy. And for us, it's very special. In this month, stay you here with us. Thank you.
no, thank you. No, thank you. I actually have seen some of them, and obviously it's in Portuguese, so it's difficult for me to follow. But it's really a big achievement already in 1 year that you had so many podcasts presented over the last year.
A great work, and to talk about physical therapy. I think that's
Yes,
really
it's our
wonderful.
passion.
Yeah, it's our passion. That's it. So, Rick, for our beginning, I would like to hear from you about our history. What have we done? How did we
Yeah,
get to the physiotherapy in the ICU that we have nowadays? What's
yeah,
your knowledge about the history of physiotherapy in the ICU?
yeah. So I've been part of the history of physical therapy in the ICU. I started as a physical therapy in a surgical ICU in Amsterdam in 1979. And so actually, it's important to understand the present, that you know where you're coming from. And in the actually before I started in the 50s, 60s, and 70s of the last century, that was a starting point where physical therapists became involved in the treatment of patients with respiratory conditions. And I think specifically the polio epidemic in the US, the prevention and treatment of post-operative pulmonary complications really made, let's say, the first steps for physical therapy in that area. And also during that period in the late 70s and starting of the 80s, in those days, ICUs were introduced in hospitals, and the first societies were also established in these days. And physical therapies started to be introduced in the treatment of critically ill patients, specifically patients suffering from respiratory failure after surgery, chest trauma, patients with neurological conditions. But then in those days, it was really focusing on the chest physiotherapy, treating the acute respiratory condition. Specifically, the book that was written in the early 60s and revised in the 70s and 80s by the UK colleagues Gaskell and Weber. They wrote a book which is entitled The Brompton Hospital Guide to Chest Physiotherapy. And that book had a focus on this area of chest physiotherapy. And that was a guide for many physical therapists like me that started working in the ICU. It was really a guide on how to practice airway clearance techniques, cuffing, chest clapping, vibration, although already in the 80s, it was considered not to be a very effective modality of treatment. And those days, physical therapists were still very active in chest clapping and chest vibration. but also breathing exercises, postural drainage, the introduction of intermittent positive pressure breathing, blow bottles, the start of incentive spirometry. That was actually established in those days. In these days, bed rest was advised in many health conditions. So after heart infarctions in patients with pneumonia, patients admitted to the ICU, and that was specifically meant to optimize the physical conditions by preservation of metabolic resources, allowing recovery. And so therefore, bed rest was considered an important component of the treatment. And that strategy of bed rest was also applied for the ICU patients suffering from critical illness. And so therefore, in those days, and I still remember that, we were focusing mostly on the chest. And obviously, we also had concerns about joint mobility, but actually, physical rehabilitation was only started at the time of discharge from the ICU.
And that was with a lot of bad functional results and weakness and
Yes,
all that for the survivors.
Yes, indeed, Saint-Clair. And the observation that indeed, although the short-term effectiveness of being admitted and treated in the ICU was improved during those days, and survival was better, still the role of early mobilization was not considered in those days. And even although already in the early 1980s, there was a book entitled Chest Physiotherapy in the ICU. And in that book, most of the content was devoted to chest physiotherapy, but there was already a chapter on changes with immobility and methods of mobilization. So although still the focus was on the chest, at that time, they already considered that maybe other components should also be considered in the treatment. And one of the physical therapists that was really critical, I think, in considering that early mobilization might be an important component was Elizabeth Dean, who together with Jocelyn Ross from Canada, from Vancouver, and they had the first paper in physical therapy on the role of body positioning and mobilization as therapeutic interventions. So that was in the late 80s, but it still took until, I think, early 2000 before the role of early mobilization was considered to be important. I think up to that time, we really had a period where effectiveness of chest physical therapy was questioned, and our area of physical therapy in the ICU, the profile of physical therapy in the ICU was really downsized. I still remember that at the start of ICUs, physical therapists were considered to be members of the team. But at that time, 24 hours of availability of physical therapists, 7 days on 7 days, was considered very expensive. And oftentimes ICU managers and hospital administrators considered that several of the chest tasks of physical therapy could be replaced by nursing staff or respiratory therapists in countries where these professionals were available, specifically in the United States. And I really considered that there was a period where physical therapy almost disappeared from the ICU team, and we were still active in the ICU, but only on specific physician order. And so that's, I think that in those days, we were not very well known and didn't have a high profile in the ICU. And that's, I think coming back to your question, Saint-Clair, that actually took a while until, let's say, the early 2000s, when intensivists showed actually significant improvement in survival rates of their patients, and became a little bit more interested in also the longer term health status of these survivors. And then it was really the paper of Margaret Herridge, well-known Canadian intensivist, who showed in a paper on 1 year and later on 5-year outcomes of patients surviving acute respiratory distress syndrome, that indeed the extrapulmonary consequences of critical illness were very important in terms of outcome of these patients. At that time, muscles not part of the assessment of patients who were admitted to the ICU. And I think it was mainly the work of the French intensivists, and specifically Bernard de Jonge, who in 2002 reported on the incidence of what is nowadays called as ICU-acquired paresis, or ICU-acquired weakness, where he reported that weakness was identified as an important contributor to the functional status, and later on also shown in papers from our hospital, for example, an important contributor to survival. So that really made the focus on muscle function, limb muscle function, and later on also respiratory muscle function. And I think talking about muscles, then of course you get in touch with physical therapy. And so at that point in time, we started to measure muscle function, muscle strength, and later on, in 2008, I think the first papers were written on early mobilization by Schweikert in the Lancet and Pete Morris in Critical Care Medicine, where he showed the effectiveness of early mobilization when physical and occupational therapy were included in what they called a mobility team. At the same time, it was really the effort from Dale Needham, from Johns Hopkins University and Hospital, where he published a paper in JAMA on the importance of early mobilization in patients in the ICU, really focusing on improving physical function and reducing hospitalization. And I think that these publications were really game changers for our profession in the ICU, moving not only, let's say, not moving away, but adding to our profile, but also the problems related to the deconditioning and immobility of those patients, and the consequences specifically of what is happening during an ICU stay, for what's happening not only during an ICU stay, but also after being discharged from the ICU and hospital.
That's such a great history. And I think that at this time, at 2000, 2008, all the physiotherapists probably got just really excited with the results and from the game changing of being unknown in the ICU and having not a lot of evidences and for the responsibilities. And then you have a lot of things and all the ICU professionals looking forward for the functional and the muscle and the strength. And that brought to our profession the importance of our presence in the ICU.
Yeah, definitely. I think the history, as I showed, as I mentioned, it is also partly coming from a very nice paper that Michelle Coe and Bronwyn Connolly wrote on the history of physical therapy in the ICU. And so for those who are interested, you really have to go for more details on that history, specifically related to the inactivity to that paper.
Yeah, but yeah, this paper is very interesting. But it's very interesting to talk about this with you because you have participated of this history of physiotherapy at ICU. It's very interesting. In this year, I went to Belfast conference,
Yes,
early
we met.
rehabilitation. Yeah, and I think it's very interesting see what's the new ways of physical therapy have seen for the future. Né? And in your opinion, what is the current role today of physiotherapists in ICU? Thinking about the patients, thinking about our profession, think about the research. What is the current role of the physiotherapist?
Yes, I think that what we described in our recommendation in 2008 on physiotherapy in the ICU is that we established with an international group of physical therapists and intensivists, and we identified 3 areas. The first area is the area related to the respiratory condition, and specifically issues then that can be addressed by our interventions, atelectasis, secretion management, but also, and more important, weaning from the ventilator, because we know that quite large fraction of patients who are admitted to the ICU and on the mechanical ventilation do have difficulties in getting liberated from the ventilator. So that's one area. And then the second area is the area of the physical deconditioning, where we had much more focus on in the last, let's say, 10 years, coming supported now with really evidence from randomized controlled trials. And I think also not to forget is our contribution as member of the team to the emotional and psychological condition of a critically ill patient. And so I think with that, we provided a kind of a profile, an inclusive profile, where physical therapy was not just physical therapy in the ICU, but was physical therapy in the ICU with different areas of importance and contribution to the treatment of the critically ill patient. And with that, I think we, over the last years, again, we established to be really a member of the ICU team. Although I have to say that this is not really established, I think, worldwide, but more and more ICUs consider that physical therapists are a member of the team taking up responsibilities in their area, and not people that are waiting for orders and referral. But I think we should, with our own professional view, those who are admitted to the ICU, we have to identify those patients that are in need of physical therapy. Although, again, in some countries, legislation might be a, let's say, a reason why physical therapists are not, let's say, really full members in that perspective in the ICU. The role that you as a physical therapist should take up in the ICU is a role where you are a full member. And that means that as other professionals do in the medical area, in nursing, that prior to your treatment, you should, let's say, take via assessment and information that you get from the patients, with that information, identify if there is an underlying problem that is amendable with physical therapy interventions. And then with further assessment, define what kind of strategy or intervention that you're going to apply in that patient. And secondly, I think also very important is that it's not only that you once you decide to treat a patient, that you also need to evaluate the effectiveness of your treatment. And so bringing in interventions is not sufficient. You also need to follow up on what is the effectiveness of your intervention. And nowadays, and there's so much information available on the ICU, it's physiological. All the physiological information is actually readily available. So if you apply an intervention, there's a lot of information available that provides you information with, let's say, how helpful your intervention is, or is there any side effect or any harm that's occurring to the patient. So all that information is also something that you as a physical therapist should take on board and use in adapting your treatment strategy, or information that you should share also with nursing staff and the medical staff.
Rik,
so that's more, let's say, in general approach.
We have talked in a lot of other episodes here about the autonomy that the physiotherapist, he or her should have autonomy to decide the intervention. And that's exactly what you just said, that we need to have a responsibility and to decide the interventions that are better at the right time for the patient. And I think that's one of the things we wish the most for the physiotherapist, that we can decide our intervention, especially because we are the professionals that study this kind of things. We are the profession that put in practice this kind of rehabilitation strategies, not the others. So how can we wait for other people to decide if they don't study as hard as we do this kind of intervention? We should be the ones responsible for that. And so your speech is great to focus on that.
Yeah, I fully agree with that. Although, of course, it's an ICU team, which actually means that the members of the team, the nursing staff, specifically the medical staff, they of course have also, like we have, our expertise. And in, let's say, in some of the decisions that we might take for our patients, it might also be that you consider that based upon your observations, based upon your knowledge, you might take some actions, but at the same time, it might also be that you share your views with the nursing staff or medical staff to say, well, this is actually my appreciation for the situation. This would be my approach to tackle the problem, and just ask advice, discussion with them to finally discuss or to finally decide on what to do in that particular patient. So it's on the one hand, of course, being autonomous. On the other hand, it's not because you have a certain autonomy that you should not be one of the, let's say, the ones who negotiate. Like nursing and medical staff might also ask our advice in terms of what they are going to do and what our opinion is. So, but again, if you want to be a member of the team, and that's something that I oftentimes observe, and still in those days, is that if you are considered, or when you consider yourself as a member of the team, then you have to acknowledge that the medical and the nursing staff specifically are, let's say, full-time, 24 hours, 7 on 7, available. And what I oftentimes see is that I do not consider that physical therapists should be present in an ICU during the night, but at least it should be that you are, let's say, providing a service where still also on the let's say, 8 to 5 hours, physical therapists are available, and just interventions that are needed by physical therapists between 8 o'clock in the morning and 5 o'clock in the evening can also be applied in hours different from those hours. And so that's let's say, if you take responsibility, you have responsibility, and that's not responsibility for from 8 o'clock to 5 o'clock, but it's responsibility that extends longer. And again, the impression is oftentimes in ICUs that physical therapists are jumping in the morning, and then someone else jumps in the afternoon, and another one jumps in maybe in the evening. And that's not the continuity of care where you can take all the responsibility. So that's something that I think can be improved in improving our profile as really members of the ICU team.
It's really great. But it's a hard work to get to this ideal profile of physiotherapy in the ICU. And then I would like to ask you, what are the skills you think we need nowadays, to get closer to this profile? And for the future, what skills do you think that the physiotherapists should have and should develop so we can get to a high profile physiotherapy in the ICU?
Yeah, thinking about all this topic, I think how is the best professional at ICU, né? How on schools and the hospital, how constructed, how learning these students and these professionals for the needs of ICU physiotherapists?
I think that education programs for physical therapists, the ICU, or in general maybe cardiorespiratory, is not the largest part in their education. Most of the programs will have, let's say, some involvement, but a little bit depending on the duration of the education. For example, in Belgium, we have a 5-year program, which is 3 years of bachelor's and 2 years of master's. And in the master program, in the second year of the master, students select a topic, and they go either into musculoskeletal, rehabilitation in neurological conditions, in pediatrics, in mental health, and the 5th one is in cardiorespiratory. And the cardiorespiratory specialization also includes ICU. And so that makes that every physical therapist coming from our program has in the bachelor also a part on cardiopulmonary rehabilitation. But those who want to specialize in that area, they follow the master course in cardiorespiratory physical therapy. But that's obviously not the case everywhere. Some programs maybe 4 and 5 years. In several countries, they organize a specialized training for physical therapists after their graduation in different areas, including also in cardiopulmonary. But that's not, let's say, that's not available, I think, everywhere. So optimally, if we, and that's where we are moving to nowadays, for example, nowadays, physical therapists who trained in pediatrics as a specialization, well, I think they don't want to treat patients who are admitted to the ICU unless it might be a pediatric ICU. So we are really now focusing on different specialization areas like we have in medicine. And so we have to acknowledge that if you have a basic training as a physician or as a physical therapist, then you have some common knowledge, but specialized knowledge is something that you gain afterwards. And part of that can be training on the spot. But I think specifically in our area, obviously, you have to build knowledge in, let's say, what is critical illness, what are the consequences of critical illness, what is respiratory failure, what is sepsis, what is mechanical ventilation, what is the metabolic, what is the medication, what is happening to a person who is critically ill, suffering from sepsis, oftentimes in a catabolic status. What are the effects of inactivity? You need information on cardiopulmonary interaction, and that's all, let's say, additional information that you have to gain. And sometimes you can gain that information by following courses at the level of the hospital or at the level of the university. I remember when I trained as a physical therapist, I followed courses in the Faculty of Medicine. I followed courses that were provided to intensivists. So it's a little bit eclectic. And at this point in time, there's, let's say, at least not worldwide, there's no specialization in, let's say, in this area acknowledged by the government. Well, we have it now in Belgium, but I think we are one of the first in that area. It might be also in Brazil, because you have also a lot of expertise in that area. And the European Respiratory Society came up with a kind of a curriculum map related to the respiratory area, including also intensive care. So these can be starting points to support those who are starting working in the ICU with what kind of knowledge do I need, what kind of skills do I need. So that's actually, well, there's no, let's say, there's no rule on what should be in it. What we did over the last, let's say, 20 years, and that's not also available in Portuguese, and that was a translation of a book on the manual práctico Fisioterapia. Here I have it, and
this.
we just I'm just finishing almost the revised version. Deborah Campos and Yves de Souza helped me tremendously, because my Portuguese, of course, is awful. So they translated, which actually also is now available in English. So that's actually where we wrote down what we in our ICU are doing, and that might be just, well, a guide, or might be helpful for others to see, well, this is what you can do, but it's not an obligation. For example, in our manual, there's not too much information on non-invasive ventilation, for example. And I know that a lot of physical therapists, for example, in Brazil, are very active also in non-invasive ventilation. But that's in our country, in our hospital, non-invasive ventilation was mainly performed by the intensivists. So therefore, well, they took that part, and we are, let's say, we are in part involved, but not really the ones who are putting patients on non-invasive ventilation. And so therefore the profile might really differ amongst countries, and even within countries that might differ. And that's something that is up to decide by the ones who are working.
So we have Deborah has the book, and we had Yves with us in one episode a few months ago, and he talked about inspiratory muscle training. It was a really good conversation we had here, and he also talked about the time that he spent with you and about the book as well, and it was a fun episode we had here. And Rik, how do you see the future? What do you expect for the future of physiotherapy in the ICU, especially?
Yes. Well, I think we
Being
haven't.
part, as you have been part of the history, and you have
Yeah.
just spent so many time working for a better profession, how do you see the future?
Yeah. Well, as you know, I retired recently, and one of my experiences is that it's really strange to think about the future when you're not part of the future, because in Belgium we are considered to retire, and for the university I have still some small tasks, but in the hospital you're not allowed to practice anymore after the age of, and in my I returned at 66. And so then you're not allowed anymore to practice in, at least not in the university hospital. There might be other hospitals where you're allowed, and I can work in clinical, in private practice. But, and so it's a little bit different, let's say, to appreciate that if you think about the future and not being part of that future feels a little bit, well, awkward, I would say. But of course, I have my ideas on how we can move on. And I think there's certainly areas. For example, one of the very interesting areas is in terms of assessment is the use of ultrasound. Ultrasound for the lungs, for the respiratory muscles. And the interesting thing is that ultrasound is something that we can use in our hands. It's not like radiography. Ultrasound is an assessment tool that we are able to use in any, let's say, patient population, including the ICU population. And that might be helpful to further address, for example, what is the problem in the lungs? Is that a problem? Is it a pleural effusion, for example? Well, pleural effusion is probably less amendable with our interventions. You can assess the effectiveness of your intervention with sonography. What is happening to the muscle? One thing, of course, is that we actually, in our ICU population, we have no information. Well, we have current information on, for example, muscle force and muscle mass, but we don't know where it's coming from, how well or how bad were muscles prior to be admitted to the ICU. So ultrasound nowadays allows us to have also assessment of muscle mass at least, and even not only the mass, but also the quality of the muscle at the initiation of being admitted to the ICU and over the course of being in the ICU. So that might be a very interesting add-on assessment tool for us as physical therapists. Another, let's say, very interesting area, I think, for us is focusing on the respiratory area. Is that again, coming back also to the respiratory muscles, is that there's now evidence that in patients who were admitted to the ICU and on mechanical ventilation, that the atrophy of the respiratory muscles, and specifically the diaphragm, is maybe in part due to injury, because these muscles have to work hard or are, let's say, deconditioned because of too much inactivity. And it's also interesting for us as, let's say, the muscle women and the muscle men, as physical therapists, to be involved in how we can optimize ventilator settings, not only indicated by the lungs and the need of the lungs, but also the needs for the respiratory muscles. So that's really, I think, an area. Also, inspiratory muscle training is an area where I've been working in for a while and still are involved in. when we train the respiratory muscles, we might have different strategies. That might be by general exercise, it might be by inspiratory muscle loading, but then we don't know maybe how much load we are putting on the muscle. If you only measure the load that the muscles have to overcome due to the external resistance, we have very little information on what actually is the load that is coming from the internal resistance, the elasticity of the lungs, the chest wall. So that's also a very interesting area, I think, for us as physical therapists. And going then to the important area of early mobilization, I think a very critical question is what is the appropriate timing? On the one hand, of course, you should not start too late. And maybe that's what we did in the past. We started too late at the time that patients were stabilized and ready to be discharged from the ICU. But nowadays we start earlier, and the question is, well, maybe in some cases we start too early. And what are the markers of maybe starting too early? How do we know that patients maybe are still in a catabolic status where you should maybe avoid too much activity of the patient? So it's information where we really are in need of somewhat more information on the underlying pathophysiological reasons for not being, or maybe being mobilized not at the appropriate timing. Let's say those conditions, but also the views from different members of the team. That's also, I think, a responsibility in part of the physical therapists who are considered to be the front runners in that process of early mobilization. So you need to negotiate with the other team members. It might be that you're lacking sufficient staff. That's also an issue. And of course, it's interesting to introduce more and more equipment in the ICU. But we actually know from the COVID-19 pandemic that was very difficult to bring in equipment in the ICUs because of the prevention of having COVID-19 over the whole place. So it's also interesting, I think, to think about what are the easy ways to mobilize our patients, to activate our patients, and to think about, well, what is the what can we do with not too much equipment? And nowadays the bed cycle is very popular, and I think that we were the first who introduced the bed cycle from a German company that made the first prototype for our hospital. And nowadays, wherever you come in the ICUs, there is bicycles, bed cycles available. And it's interesting, of course, but it's very costly. And we also have to think about what might be alternatives, specifically for those situations where there might be alternatives for that oftentimes also very costly equipment. So that's, I think, also a challenge for us as physical therapists to think of outside of the box and think about what can we do with in situations where not all equipment is available. And then maybe a final thing where I've been involved in still at this point in time, related to the emotional function of our patients. Nowadays, reduction in sedation, of course, is something that is advocated by medical nursing staff. Not always possible, of course, because of the the level of critical illness of the patients, but there might be also avenues for virtual reality where we can change the environment. And we have been working over the last year in our ICU with prototypes of virtual reality for patients who are in our ICUs. And both, well, there were different issues that were addressed with virtual reality. On the one hand, it was kind of a sedation or relaxation, I have to say, but also encouraging activity where patients were able to move their arms, and with that movement of arms were able to interact with virtual reality with painting, for example. So that's I think also a new avenue that where we have to further build on in the future, because more and more patients are admitted to the ICU, and of course a significant fraction of patients who are admitted to the ICU stay for a longer period of time in the ICU to recover, to allow vital organs that were failing to recover, to be supported. And that long duration is also a period where long periods of inactivity have to be faced. And well, I think also from that perspective, we can help to create an environment for patients with virtual reality, but also with music. There's very nice papers also on how music can help patients to well, to get emotionally better. That's also something that we as physical therapists, as members of the team, should be open for, that kind of new avenues.
It's really great. I would like to make an extra question. We are heading to the end of the episode, but I would like to, it's not a question, it's I'm going to ask you a favor. We have a lot of students that hear the podcast and professionals that just decided to work in the ICU, and they are looking forward to be a better person in the ICU. And what would be your tip for this kind of person that wants to work in the ICU as a physical therapist? And what should they do to work their passion for the ICU physiotherapy?
Take it home.
Yeah, what's the
Take home
take-home
message.
message? Yeah, for them,
Yeah.
One of the things that for me is important in the education of students is that every student has to meet his or her future self. So it means that during our educational programs, we already should allow patients or students to encounter well, different profiles of, well, what is my perspective of being a physical therapist in the future? Is that something that I would do with children or with adults, with the geriatric population? Is that more in musculoskeletal? And so students should have a kind of a example of that really attracts them to go into that area. So I think the best thing for students, if they have an interest in that area, is to get in contact with a colleague who is working in the ICU, and then that colleague can take them on board, and that might be, let's say, that might be in a situation where that physical therapist, young physical therapist, is still engaged in a hospital. But it might also be that someone is maybe not at that point in time engaged in the hospital. But for example, COVID-19, of course, opened the eyes of many people, for patients, but also for our profession, what physical therapy can do in the ICU in patients who were dramatically, for a long period of time, admitted to the ICU in isolation oftentimes. So what I think is important, if you are interested, well, on the one hand, I think that in our educational programs, we also should provide a broad view on what can a physical therapy do as a profession in the healthcare area. It should be a very broad scope. And for those students, so that's the first contact with that students then have with different areas in our field. And for those who feel attracted to the ICU, but maybe do not have the full experience on what it is, what you're actually doing, well, contact a physical therapist who is working in the area. And I'm pretty sure that every physical therapist and also every physical therapist working in the ICU is proud of his or her work in the ICU and would like to share that with young colleagues um, who wants to be involved in that area. And from that point on, then of course you have to establish, well, what are the opportunities to further specialize in that area? What kind of information do you need? What kind of training is available? What kind of courses are available? And I think that's not very different from how I started many years ago as a physical therapist, unknown in the ICU, because for the full history, at the time that I started in Amsterdam in the Free University Hospital, I was actually looking for a job in the outpatient clinic for manual therapy. At that point in time, but there was no available option at that point in time. And they said, well, we have an option for the ICU, but I had no clue what physical therapy in the ICU was. And fortunately, working in a university hospital, I met intensivists who were really interested in what physical therapy could do for that patients. I had a colleague who was interested in the area. So together we worked on, let's say, on building our knowledge and skills in the ICU. And I think nowadays still you need to meet with people that are really helpful to take you to the next stage in your professional career. And of course, there are some, let's say, there is of course available information where you can have somewhat more details on what is the profile of a physical therapist in the ICU. And for example, we also developed a DVD on physical therapy in the ICU. And if you're interested, I can share with you the DVD, and it's no problem to share that with others. So I'll send you that. We have that book, of course, but a book is a book, and it's really the appreciation is, well, when you are in real contact in the situation of being in the room of a patient who is admitted to the ICU, and where physical therapists are working with those patients. So it's a long answer to a, let's say, a very important question. But at this point in time, since we have no, at least to my knowledge, not really in many countries, a education program for physical therapists who are going to work in the ICU. Or do you have it in Brazil?
Yeah, we have some specialization courses, post-graduation courses, but we don't have a program that when someone gets to work to the hospital, it's offered a program. The person has to look for the program before she or her or he starts to work in the ICU. So we don't have a formation program before people start working in the ICU. We don't have that.
Yeah. Well, I think that's very common. That's very common.
And probably that would be a big step to bring good professionals to the ICU when you work them before they do the work and the shift, and they know what they are going to face, and probably going to have better professionals.
We have students that graduate in our specialization in cardiopulmonary or it's called actually rehabilitation and physical therapy in internal disorders, including also ICU. And these students are very much interested in that area, but do not have all the skills at the time that they start with us. And so at the time that they start with us, they still need quite a lot of guidance by the more senior physical therapists in that area. And gradually, of course, they are becoming the experts. It's a matter of not only time, but also content that you provide to them. So we allow them, for example, to follow additional meetings, for example, every week, and that will probably be the same in every hospital, at least, and every university hospital, that we have weekly meetings where they discuss specific topics, papers, cases. We have invited speakers, and so that's the way actually you build your knowledge. And again, at this point in time, also for specialization in our area, we do not have a very final examination specifically addressing all the skills that you need as a physical therapist working in the ICU.
I totally agree. We work with students. I work with students here in graduation, and Deborah works with student in graduation as well. And we don't have time enough to teach them most of the things that they need to work as a physiotherapist in the ICU. So we have to teach just some basic stuff, and then they go out, and if they want to work, they have to make another course. And it would be wonderful if we had a program and a course that we could go deeper in the knowledge about the physical therapy in the ICU. That would be wonderful.
And we created this podcast to up our knowledge about the physiotherapy at ICU. And Ricky, it's very special for us. You stay here in our podcast. I remember when I went to Liver at the conference. I think the 7th, 8th conference. I don't remember before the pandemic.
Yes, I think it was 17 or 18. 18.
I remember when I stayed living for many days, and all the people loved Rik. All the people loved Rik, and now this year on Belfast, all the people loved Rik. And for us, it's very, very special because we in Brazil we read your papers, your book, and it's very important for us and for our profession. Stay with here today. Thank you very much for talking with us about all topics.
No, it was my pleasure, and it's really an honor for me. And I have so many colleagues and friends in Brazil, and unfortunately, it's already a long time. Well, I think 4 or 5 years before COVID-19 that I had my last visit to Brazil. So hopefully, there will be new opportunities to come your way. But
we hope you can come here as soon as possible.
And Ives stayed here with us and talk about Rik. And Chris Perm stayed with us and talked about Rik. And all the people talking about Rik.
It was a really great conversation, Rik. I would like to thank you very much for your time and being available to talk to us. And everybody that listens or watch the podcast is going to have a great view of physiotherapy in the ICU. You really brought to us what we did before, how did we build this profession, and how scientific evidence brought better ways to work and really good insights for the future. So we thank you a lot for being here with us. and we hope a lot of people get to hear or watch. And especially, we hope that you can come to Brazil as soon as possible, so we can all have you here talking about your experience. And I know that you just had a great granddaughter, so you gotta have some fun time with your daughter and your granddaughter.
Yeah. Well, next month in November, I will be in Chile for the Chilean
That's really close.
Intensive Care Society. Yeah, with Daniel Arenello.
Daniel Arenello and Rodrigo Torres Castro.
Yes,
I know some people.
Yes,
Rodrigo.
Yeah.
Great. It's gonna be really close.
Yeah. So we'll have a flavor of South America.
Yeah.
Not the flavor of Brazil, and definitely not the flavor from the Nordeste. That's a very special area. We have not been
it's a good place.
We have not been to Natal, but we have to Florianopolis, to Pipa. Very
Pipa.
special.
Pipa, it's really close to here.
Yes.
Pipa, it's about 1 hour from my house.
Yes. Yeah.
It's a good place, really good. So I hope we're gonna work this out, and me and Deborah are gonna find a way to bring you to Brazil.
Will be my pleasure. My pleasure. So thank you very much. Deborah. Thank you very much, Saint-Clair. Muito obrigado. It was really a big honor for me. And say hello to all the good friends in Brazil. And so hopefully we'll share thoughts in the near future.
Yeah.
Great.
Thank you.
Thanks a lot.
See you, Rik.
See you. Okay.
See
Bye-bye.
you.
See you.
Bye.
Thanks,
Bye.
Deborah, and thanks everyone that followed us until now. Bye-bye, people.
Bye-bye.
See you in the next
Bye-bye.
episode.
Yes.
Yeah.
Bye-bye.